We can start now, sir.
Good evening, friends. Welcome to today's academic webinar, which is conducted every month by Department of PMR SVNIRTAR under the aegis of Association of Physical Medicine and Rehabilitation of Odisha and Indian Association of Physical Medicine and Rehabilitation. Today's discussion is something different. That's shoulder pain and myofascial chain, a holistic approach to shoulder pain. Friends, shoulder is a very complex joint. We find a lot of shoulder pain patients in our everyday OPD practice. And you all know this complex joint is formed by glenohumeral joint associated with scapulothoracic movement and acromioclavicular joints. And these complex movements are joints is the movements are accomplished by the synchronized action of number of muscles, starting from deltoid, which helps in abduction at a glenohumeral joint, and the rotator cuff group of muscles, especially supraspinatus, which engages head with the glenoid to initiate the abduction, and the parascapular group of muscles, which helps in overhead abduction. So the traditional thought that each muscle has its individual action, like deltoid causes abduction. So actually, this is not true. The initial part, shoulder abduction and glenohumeral joint up to 60 degree. Beyond that is scapulothoracic movement. But actually, these movements occur in a synchronized manner, not by phase manner. So similarly, the muscles are also not act isolately. They act in a synchronized manner. So the traditional concept of for any individual movement, a single muscle is responsible is not standing true. It is gradually changing. The concept is changing. The current concept is that the muscle do not work like a single unit. It actually they work together as a part of interconnected anatomic chains to accomplish a particular movements, and this chain is also called myofascial chains. So today we have with us Dr. Ravi Sankaran, the professor and head of Department of PMR, Amrita Hospital, Kochi. He is an expert in that. He will today talk on the shoulder pain, a holistic approach, including this myofascial chains. His special interest is on spasticity, disorder of consciousness, peripheral nerve injury rehabilitation, cardiac rehabilitation, and more specifically, he has much interest in pelvic floor reaction. If you look to his academic career, he has a brilliant academic career. He joined Amrita in 2009 after residency in Michigan State University. He also got his primary certification for hyperbaric underwater medicine 2013, spasticity surgery fellowship in Tokyo Women's University, Japan in 2014. He started India's first physiatrist-led hyperbaric oxygen therapy service in 2014. He is the first physiatrist doing pelvic floor rehabilitation in India since 2019, and he is the first physiatrist to represent India in Bologna, Italy for neural therapy in 2022. So he has a brilliant academic career and is a good speaker. We have heard many lectures in different conferences, especially his lecture on pelvic floor exercise is very interesting. And also he has a different concept of managing different types of pain. So without much wasting of time, let me invite Professor Dr. Ravi Sankaran to present his talk on shoulder pain, a holistic approach. Over to Dr. Ravi. Thank you.
Good evening, everybody. So I'm here to spice up your Saturday night with some boring theory, but we'll look at a holistic approach to shoulder joints. So, okay, what went wrong? And what we're looking at is just a little case just to get things started. So imagine you go to clinic one day and you see a patient who says, "Doc, your injection failed me." something nobody really wants to hear. But here we have a case, and he's a 53-year-old male with adhesive capsulitis, and he's come for follow-up 3 months from his first visit. So in the first visit, you gave him a suprascapular nerve block and some home exercises, and his pain, 100%, drops to 40%. That's a pretty good relief. And he goes home with home exercise, but he defaults on the exercise. Now, one would wonder, is that the reason why he's come back worse, blaming us? There's other factors involved that we don't often look into. And those are things like the fact that this patient is obese, he has diabetes, he has swayback. So we want to know what went wrong. Why did our procedures not really help this patient? And for that, we have to kind of shift our thought process. So there's approaches that you can take looking at the shoulder. The traditional one is to look for a condition to label and then treat the label. That is what population-based medicine is. There's another approach you could take. It's a little bit harder, it's a bit more complicated, it's holistic, and it's to look at local factors, then to look at global factors, biochemical factors, lifestyle, and psychosocial things. And this is a much more personalized approach to healthcare. Anybody would be happy receiving personalized care, but this is what it takes to get there. What is that traditional approach? The thing we all know so well? You got a history. And the history is, this person has history of pain in the shoulder. Nothing new. Difficulty with upper extremity ADL. So that's a challenge. And this is the history we look for to say, this could be a shoulder problem. The exam shows that the shoulder joint is painful. There's restricted range of movement for the shoulder. And from there, what do? We get some lab work. So acute phase reactants, usually not. HbA1c may or may not be high if they're diabetic. You can get some radiology done. X-rays might be normal. MRI might show you some thickening of the capsule. And from there, we make a diagnosis. And from there, we treat. And we treat this label, the condition that we've diagnosed, using evidence-based medicine, guidelines, and whatever we actually prefer. We have our own level of skill and biases. So this is the traditional approach. It's one we know quite well, but we have to shift our thought process a bit. And that starts by just realizing muscles are connected to each other via joints. It sounds so ridiculously simple, so let me show you how that makes a difference. When we realize muscles are connected by joints, we know that muscles that don't behave properly will make problems. Imagine a muscle is now overstretched. If it's overstretched, the joint won't have its full range of movement, or it might sit at rest in a different position. You could have muscles that become short and tight. If they become short and tight, they can pull the articular surfaces towards them, again, restricting range of movement and preventing proper function. Sometimes you get short and tight muscles with loose muscles. So this is essentially the crux of looking at myofascial chains throughout the body. But we're going to take it a little bit further by turning these muscles and joints into levers. Now, we know from physics there's 3 different types of levers. There's a class 1 lever, the traditional one, where there's a fulcrum in the middle, a force on one end, load on the other end. There's a class 2 lever, where the fulcrum is on the end, and the load or the force is going to be otherwise. And the class 3, which is the reverse of class 2. Now, when we talk about the glenohumeral joint, we're talking about class 3 levers. And this lever is a little bit different because it has forces pulling it up or down. So here, the forces that could pull it into a flexion movement would be things like pectoralis major or coracobrachialis. Things pulling into extension could be latissimus dorsi or the posterior deltoid. Now, that's a simplified concept, but this is how our glenohumeral joint actually works. The thing is, it's not just a glenohumeral joint. We have a sequence of these joints have tandem levers that run throughout the extremities, and we have to understand how these joints all come together. So it's not that there's a shoulder joint floating around in space, it's connected to the sternoclavicular joint. which is affected by trapezius levator scapulae or sternomastoid. Then you have the glenohumeral and the muscles we spoke about, but that connects down and affects the humeral ulnar joint. So that's acted on by biceps brachialis and triceps. And then there's the radial ulnar joint, which can be affected by pronator teres, FCR, or supinator, ECRL, ECRB, and ECU. So we have all these different muscles acting across a series of joints that are connected to each other that all behave like levers. But it's not that. It's a little more than that because muscles are prone to assume dysfunction patterns. So if you look at our trapezius levator scapulae, when we see periarthritis shoulder, very likely upper trapezius will be short and tight, levator scapulae along with it. Sternocleidomastoid could also be tight. So now you have two proximal muscles deforming the sternoclavicular joint. And that starts to manifest below, where pectoralis major coracobrachialis becomes short and tight. But here, the antagonist muscle, the latissimus dorsi or posterior deltoid, gets overstretched. And now you have a glenohumeral joint, our shoulder joint, that's getting deformed. And this joint tends to move into an adduction internal rotation position. The next is a humeral ulnar joint, where we have some relatively normal groups of muscles like bicep brachialis, but tricep, again, will get overstretched. And then at the radial ulnar joint, again, things become kind of normal again. But when we see a lot of shoulder dysfunction, this is the underlying muscle imbalances. So just looking at a shoulder joint and treating that isn't really correct because we won't treat the underlying problems, which is what these are. And again, we're back to levers again. So here we have a class 1 lever, but the rest of these are all class 3 levers. Now, simplified, this is what we're looking at. A series of proximal muscles that are really, really tight, intermediary muscles on the extensor surface that are overstretched, and distal muscles that are relatively okay. Superimposed onto the upper extremity, you can see how all these things come together. This is the reality of what we're dealing with when we see a shoulder dysfunction. It's not just the joint, it's much, much more. And what you saw was one myofascial chain. Now, in the limbs, we have 4 myofascial chains. So there's a superficial anterior, there's a deep anterior, there's a superficial posterior, deep posterior, and all these chains are interlinked to each other. So when they're interlinked, dysfunction in any one muscle can make problems for the other chain and throughout. Many people overlook these kinds of things, and that's the purpose of today's talk. So the anterior chains are prone to shorten, and people wonder, why should that happen? And the basic thing comes down to our eyes face forward. Because the eyes face forward, most of our work will therefore be in front of us. Because our work is in front of us, our limbs, our extremities will move towards the work to bring it into the field of range for the eyes. And that's why these anterior muscles will start to shorten. So we have a superficial anterior chain, which is composed of deltoid, pectoralis major, biceps brachii, serratus anterior, and even the anterior abdominal wall muscles like the obliques. There's a deep anterior chain, which has sternocleidomastoid, upper trapezius, again, the pectoralis minor, and biceps. So you can see these are not isolated entities. They don't even look like proper chains, but they're muscles that are wired together to fire together. On the posterior side, things get a little bit more complicated. So rhomboids, infraspinatus, teres minor, the deltoid, triceps, they all come together for a superficial posterior chain versus levator scapulae, upper trapezius, supraspinatus, rhomboids, and coming together for a deep posterior chain. Now, this is how these muscles wire together to provide function for the shoulder joint. When we see people who have shoulder dysfunction, the easy approach is to just look at the shoulder joint, treat that condition, and say, we're done. But there's these underlying dysfunctions that perpetrate these conditions and can make them worse. So symptomatically, they might be better, but functionally, they won't. how do you know which muscle is in dysfunction? I think all of you are senior physiatrists who know the answer. It's the standard things. Tender points where you feel a person has pain, but there's no fibrofatty nodule. Myofascial trigger points where you feel a fibrofatty nodule. If you press on a trigger point, it might radiate pain somewhere else. And people ask, why should that happen? You can see this picture on the bottom, fascia, artery, nerve. These structures are now trapped in this soluble gel that's the fascia. And if the fascia is tight or restricting it, you can pinch the nerve, you can restrict the blood flow and cause neuropathic pain or other sensations elsewhere in the body, like the picture above. Pectoralis major trigger points radiate into the anterior shoulder. And then, of course, we have the typical click, pop, or grind outside of the joint. And this is from your myofascial trigger points and other areas of dysfunction. Now, these things we can actually find out. So if you know that there's a chain in dysfunction, you can follow it proximally and distally and see which muscles are compromised to make a more comprehensive plan. Now, you've seen the local factors. The local factors are basically those chains that are on the shoulder, but that arm is not freely floating in space. It's attached to a trunk and attaches the trunk in a very particular way. Now, if you remember at the very beginning of my talk, I said, here's a person with a sway back posture. So here is the sway back posture. This is in the book Kendall and Muscle Testing. The Kendall therapist actually gave us this model in the 1960s. It's a very good way to approach simple posture issues. But the sway back posture is unique in that you can have overstretched muscles like iliopsoas, rhomboids, middle trapezius, latissimus dorsi, or tight muscles like splenius capitis, hamstrings, or gastrocnemius. Now, this pattern of muscle tightness leads to a very particular spine position. On the left, you can see a normal spine with its 2 lordosis, 1 kyphosis. On the right, you can see a sway back posture with an exaggerated thoracic kyphosis. There should be a lower loss of lordosis and a tight cervical lordosis because of all these muscle imbalances. But what I want you to focus on here is that the upper thoracic curve is really bulging out compared to the normal. And because it bulges out, it takes the scapula off of the thoracic cavity. When that happens, muscles like latissimus dorsi or middle trapezius get overstretched. And now you find the scapula starts to move superiorly or anteriorly. The muscles that attach onto this shoulder girdle complex, like pectoralis major, can start to pull. And if they're unopposed because latissimus dorsi is now overstretched or compromised, levator scapula can pull it up, upper trapezius can pull it up, middle trapezius can't hold the scapula against the thoracic cavity. The whole bone starts to migrate over the thoracic cavity into an anterior and adducted position or internal rotation. And this is how a lot of these problems actually begin. So like I said, this is how the scapula ends up in dysfunction, but the scapula is not freely floating in space, it's attached to a body. This is where things start to get really complicated. So there are myofascial chains throughout the body, and some of those on the anterior aspect would come from muscles like pectoralis major or serratus anterior, linking into external oblique or the rectus abdominis. Now, people ask, why should I learn this? But if you look at people who have periarthritis shoulder, very likely they're going to have a rice belly or a beer belly or just a weak core. Now, that weak anterior abdominal wall will allow the fascial planes to pull the scapula forward and tether it down. So if we don't look at the anterior abdominal wall, we're not going to get the scapula to go back in place to where it should be. You can even have biceps brachii and iliopsoas join the rectus femoris. This is typically for the person who's sitting in a chair all day driving a mouse or answering phone calls. The pelvis retronutates, the bicep starts to tighten up on the other end. And here we have serratus anterior joining into the adductor longus and gracilis. Again, a typical pattern you see for people who are stuck in a chair all day. Here are a few more anterior chains. Subscapularis joining into the pelvic floor. This is a nightmare. Most people don't even think of looking at pelvic floor when they see a shoulder case, but this can happen. The deep cervical flexors, like splenius capitis, the scaleni, will join into diaphragm and the psoas. This is again people who are sitting for long hours with their head forward into a screen. They won't ventilate properly and they'll have a shortened iliopsoas or overstretched iliopsoas. The obliques will link into the adductors. So again, if they're imbalanced, the adductors will overact and it can pull the entire shoulder forward. Whoops. And here's a really nasty chain. This crosses the entire midline. So latissimus dorsi of one side will now join the contralateral gluteus medius, trapezius, and rhomboids, and join the erector spinae and hamstrings. These are subtle patterns that you can learn to pick up on clinical exam, so you can address more muscles when you make a treatment plan. Posterior deltoid and triceps will join the glutei and the hamstrings. Spinal extensors will join the hamstrings, the glutei, and the erector spinae again. Rotator cuff joins the multifidus and erector spinae. Lower trapezius will join the gluteus medius and the tensor fascia lata. And the scapular retractors can join into the peronei. These are rare patterns, but we have to understand where to look for dysfunction if we're going to treat these people completely. Now, that is the extent of myofascial chains regarding the shoulder, but that's not the complete holistic picture. The next part is something we know quite well. Many of our people tend to be overweight, and because they're overweight, they have a lot of age protein, advanced glycation end products freely floating in circulation. Age protein can deposit anywhere it wants. If it sits on a muscle or a capsule, it will independently stimulate inflammation on its own. It can perpetrate inflammation on its own also. So if we don't address this overweight status for our patient, we might give them symptomatic relief, but we won't give them a cure or a long-lasting relief. It can relapse, and they could come back and say, hey, your injection failed me. Another thing we have is the modern diet. Now, the modern diet is very high in carbohydrates, it's high in fat, it's high in salt and sugar, preservatives. Everything is kind of in the wrong ratios. There's not much micronutrients or fiber. And the assumption is, because it tastes good, it must be good, but actually it's not. So looking into these kind of factors helps us get a deeper perspective on what is driving this person to be overweight and having a shoulder dysfunction. There's also a psychosocial angle to these things. This is going to be typically in your younger patients who haven't started getting sarcopenia. There's behaviors and use patterns that a person develops that leads to these local and global findings, and those could be abnormal sleep patterns, addictive substance use like bright screens. There's a lot of people who go to bed holding a phone or a screen flashing on their face that can alter the circadian rhythm and impair sleep so the muscles won't relax. Physical activity is something a lot of Indians don't like to do, and this can lead to eventually losing muscle faster than we expect. Life is full of stress. If we don't know how to manage it, it can be a problem, and this can again affect resting state, quality of sleep, and then muscles. So these are all the things we should consider when we think about looking into a person holistically. And you can often find one of these things or one of these domains, if not multiple, that are going to be impaired. So if we can address those more deeply, we're getting personalized care and getting a person a better outcome. When I give this kind of a talk, people think, my God, Ravi, why did you make such a simple topic so complicated? Or where do we begin to learn all these things? You've seen some myofascial chains, you know the names. You know there's muscles that connect through and through. You have the ability to get a history and get an exam. you can find other areas in the history that the patient reported that could be painful or were painful earlier. And you can also localize and find signs of muscle imbalances across joints. This is a skill you develop over years of doing it over and over and over again. And as you start to do this, the patient knows you are finding things everybody else missed. That adds a value to the service that you provide to these patients. So the eyes only see what the mind knows. And that's all. Thank you.
Thank you, Dr. Ravi. So the topic is discussion purpose. So let me start from my side. That this myofascial trigger chain is a evolving concept. Actually, it's not well covered by all students, all teachers. Whenever any patient is coming to us to OPD, do we look for always these things, or you first look for the underlying pathology? Any different, like we always look for whether it is a glenohumeral joint, or it's a subacromial pathology, or it is a acromioclavicular joint. I have attended one workshop by CMA by under this Professor Maheshwari. He is a well-known surgeon. He is a good speaker also. He classified shoulder pain into three parts. You start examining first, see per glenohumeral joint, the abduction external rotation is limited. So maybe most chance it's coming from the glenohumeral joint. If you find it is okay, then go for the look for impingement test, look for any subacromial pathology. If that is fine, then go for the third floor, that is acromioclavicular joint. So very often we look for these things and ignore these parts. So in your practice, do you look first exclude the pathology, then think about the myofascial chains or trigger points, or you start from the examine the trigger points, then the pathology? What is your course of examination in
So
case of
my
shoulder?
approach is everything all in one go. You have to consider, I work in a corporate hospital with all the subspecialties in full form. So when we get a patient, we get them at the very end. They've seen every single person, every possible scan is done, every blood test is done. All these people fail to understand how the musculoskeletal system works. Even our orthopedic colleagues, they don't understand it. All they know is tablets or injections and done. So when I get a patient, the diagnosis is already made. It's the periarthritis shoulder almost every single time. The question always is why. So for me right now, the simple thing is go and check the shoulder joint and see if there's restriction. If the rotations and abduction are restricted, it's fairly obvious what it is. The x-rays are already done, the blood tests are done. But at some point, care becomes educating a person as to what they are doing wrong. Because on some level, they know this. So they'll ask you, why did this happen to me? So if you tell them it's purely a subacromial impingement or it's a glenohumeral dysfunction, they don't understand that. But if you, I keep a little model on my desk of a little dummy with the myofascial chains running throughout the body. So I can show them, look, this muscle that starts here, goes over here, goes over here. And they say, yeah, I actually have pain there too. Or I can show, this chain that starts over here goes into your trunk. And they say, no, I actually have pain there too. So now we're finding things other people have missed. The patient doesn't know they should tell other people that they got laughed at for finding more pains. But at the end of the day, they know we're doing something no one else has done. We're getting information that's useful to treat with, and from there we can make a better plan. So everything happens at the same time with me. I'm often diagnosing and treating at the same go. But mostly, if it's a shoulder condition and they're amenable for injection, we'll talk about injections for them. Get them a home exercise program after that, and we see how they do. But then we tell them, look, this is not the end of it. You still have to lose weight. You still have to modify your diet. And when I say those things, it's more of sending out a feeler to see what their level of awareness is. If they think that their diet is okay, they're not going to ask anything. If they think that they might be overweight or should lose weight, they might come back and say, why is it a problem? Or how do I lose weight? So then the education process begins. You don't want to overload someone who's not ready to listen, but you can send out little feelers through the history exam treatment to see what they're ready to hear. So to simply answer you, everything happens at the same time. I check everything together, but usually we'll treat the shoulder first and make sure the patient has enough sense to understand this is more than just a shoulder issue.
Yeah, exactly. How the approach of a physiatrist is different from others. That's a bright example. If this same patient is going to a orthopedist and he think about that these three things, a glenohumeral or subacromial or the acromioclavicular. The same patient going to neurology, thinking about the brachial neuralgia because the same type of radiation will expect. But it's the physiatrist who can approach really shoulder as a holistic way, considering all these factors for shoulder pain. That's a good thing. Let's see
One
any.
thing- Sorry, one more thing.
Yes.
Many times what our colleagues see as subacromial impingement and all these things are just a manifestation of dysfunction where the latissimus dorsi is overstretched, middle trapezius is overstretched, and the whole glenohumeral complex migrates anteriorly. So they're finding the end of the problem, they're missing the entire cause.
Right, right, right. We look for the site only. We don't look for the what is the cause behind why impingement is occurring.
Yeah. And I think even you find some therapists who are wise, but most just look to apply machines and be done. So if we don't do our job properly, the patient never gets better.
Yes. So there is a compliment suggestion, compliment comments from the neurologist, sir. It is essential to comprehend the imbalance that has been established along with its underlying causal hypothesis. So it has to be a wholesome approach, not that only the disease part or the cause part, other parts should be taken care of. There is one question. Uh, it's a combination of closed chain kinematic and myofascial pathophysiology. What's the role of neural therapy once you have made a diagnosis of problem in the myofascial chain?
Oh, that's a good question. So it may or may not be. Neural therapy, for those of you who don't know, is essentially injections of low dose local anesthetics into either muscles, nerves, or autonomic ganglia. So I have used neural therapy in shoulder cases, but I'll do it as a stellate ganglion block with a hemiplegic shoulder pain. Um, Neural therapy tends to work in a way that we don't fully understand or have reproducible objective metrics for. So as a result, I leave it at the very end. There are 3 times where I use neural therapy. If a person tells me that their joint hurts because of a past trauma where there's been no damage, I would think that the structures of the fascia there has been sensitized enough where it could be desensitized and made better. Another thing is where you see people who are otherwise normal, lived a good life, but they're under a lot of stress. And what's manifesting as a shoulder problem could be a manifestation of that. So oversensitive or oversensitized, where people are now drowning in social media, doom scrolling, food that has high preservatives, and for some reason that joint gets inflamed over others. Um, I don't use neurotherapy that often. When I have, I do use it for those indications. Slightly off the shoulder joint. I'll tell you about a patient. So this one patient came to me. I'm part of an ashram, right? So we have a lot of foreigners in the ashram. One lady's from the US. She went through a divorce and came to live in the ashram, white lady. And she has very bad knee pain and she wants to exercise because her body's getting older. She's 50 or so, but she can't because of really bad knee pain. And she's had it all her life. And her sisters have it too, and it's the right knee. So I told her, look, there's many things we can do, but I think a course of prolo would help. We gave her 4 rounds of prolotherapy. Her knee improved so well she could do a squat, but she had a patellofemoral syndrome. We put some PRP in there the 5th time around, and she got really good. But she would be oversensitive if you touched her right knee versus the left. So I told her, some people, they have past trauma, something that's affecting them, and it manifests in a joint. And she goes completely quiet. And then she doesn't want to talk about it. But we go through this course of 4 Prolo, 1 PRP, and she's doing really good, but that knee won't stop hurting. So I told her we've done all the regular stuff for you. I could inject more, but let's talk about this past pain. And she goes on to say, it's not just me, it's my 3 other sisters, and the pain comes from a past life. What do you say to a person when they say that? You can't deny what they think. You can't deny how they're expressing what bothers them. If you devalue it, you've broken the trust with them. So according to her, in her past life, she was a prostitute in a brothel, and she was chained to a bed. And she would try to jump away from the bed, and that's how she hurt her knee. And her sisters had the same problem. What that really means, it's so hard to say, but you can't devalue someone's thoughts and words. Um, we did neural therapy for her, she's completely fine.
Yeah.
What did those local anesthetics do for her? I don't really know, but she's doing all the things she loves, and that's enough.
So, do you recommend that there should be some complementary therapy in the form of whether it is steroid or it is for PRP or Prolo to have instant relief and to what, because that for addressing this myofascial chain or posture correction that may take long time, and for instant relief, do you suggest any complementary management along with your the this biomechanical correction?
Complementary meaning
Like
tablets.
any like prolotherapy or steroid or PRP
Mhm.
to have your neural therapy for a short period to get instant relief because the rest part may take a long period.
This is the tricky part. So our hospital feeds from anywhere from 5. So the immediate goal of care is that this person gets some form of relief and gets something they can do to take care of themselves. And if they get those 2 things, immediate relief and the capacity to take care of themselves, then what we can do next is educate them and show them, if you get better, we're done. If you're not, these things can help. Eventually, prolotherapy into middle trapezius, rhomboids, infraspinatus, all those things do help. It's just the willingness of the patient to undergo injections isn't thing. So if they're willing right away, and some people are suffering so bad, they'll say, yeah, just inject me, no problem. Some people, they go through a course of injections and they feel better, so they're okay, and they don't need anything else. Some people need more. So we educate them and show them, yes, you can have all these options, but the best is what you do for yourself. And this is where we start to work on just diet and that kind of a thing. And that
Okay.
often scares people off. In Kerala, that means giving up a lot of rice and giving up animal source proteins. So if they don't like that, they may not come back, but they'll have been better for the time that you served them. Did I answer your question?
Yeah, yeah. There are some more questions in the chat box. Is there any postural correction and ergonomics adjustment to reduce the strain on myofascial chains?
There always is. I don't know how to show it to you through such a small screen. um, so the essential answer is, if you look at some of these posture patterns, let me pull them up. I'm going to share my video slides again. One second. Can you guys see my slides?
Yes.
Okay. So, oh, I lost it. Okay, it's here. Oops. And you can see the posture patterns here?
Yes.
Okay. So ideal alignment is relatively okay. There's no major issues. You can just treat trigger points and correct focal imbalances. A kyphotic lordotic posture, the hallmark is always this anterior pelvic tilt. I'll say this, it's going to sound very vulgar, but it's not meant to be. You can see kyphotic lordotic posture because the person has a very big rear end. The sacrum will tilt so anteriorly, all the tissues will deposit in the gluteal region, making a very prominent posterior. They also have usually a sagging anterior. So the weak core, the big pelvic tilt over here, and then a deep kyphosis with a deep lordosis here. Now, the other two patterns you see are going to have a retronutation of the pelvis. So iliopsoas is overstretched. And because it's overstretched, the pelvis starts to tilt backwards in space. So there always is a posture correction for every one of these. For kyphotic lordotic, you stretch out the tight iliopsoas, you strengthen the transversus abdominis and the obliques, and then you strengthen the internal scapulars. For a flat back and a sway back, you have to shorten iliopsoas, which is very hard to do. But you can also strengthen the interscapular muscles and lengthen out the cervical region. All of these, because their head faces forwards, will have an anterior adducted scapula. So interscapular muscle strengthening will almost always help you with shoulder issues, but it won't take care of the pressure distribution into the lumbosacral region. And that's where iliopsoas comes into play. So yes, there's no shortcuts, but if you understand the basic concept, you know which muscles to target and how to get to them.
Yeah. I can see the comments of Dr. Mrinal Joshi, sir. Sir, you can unmute yourself. You can participate in the discussion also. Hello.
Hi, Ravi.
Hi,
Hi,
Mrinal.
Ravi. Can you hear me? Hi. So it was a
Yes.
good presentation, and you know the story. And what I have learned myself over some period, and then one day, if you remember, I was discussing regarding doing an hydrodissection for the spinal accessory now,
Mhm.
and then it has,
I,
yeah. So that actually has given that first pain relief, because once the patient comes, it is very hard to convince anybody until and unless we actually relieve him with pain. And giving a lot of NSAIDs and muscle relaxant is not possible over a long period of time. So recently I've learned this, where you just do a block for spinal accessory, more of a hydrodissection, and for dorsal scapular now. And once your pain is settled, then you are actually ready for doing exercises. And as you said, that until and unless we correct the chain of connectivity of these muscles and the balance, it really doesn't work. So I totally agree with that. But this is a recent learning that I have done myself and experimented on myself also. So what are your thoughts about it?
I like it. I mean, people come to us for relief. If we send them somewhere else, they didn't get relief from us. If you can put a needle in and get them relief, that's the best thing. I usually teach exercise myself. I don't send it to a therapist. So they come to me, end-to-end care and done. So I agree with injections. There's no problem. As long as they have no problem, it's a good thing.
Okay. One more question. Other than pain in that myofascial chain, what other findings we can get to support the diagnosis?
Which diagnosis?
That the pain originated from the myofascial chain or myofascial chain dysfunction. Besides pain, what other findings we can get?
Yeah, so there are a few standard things. One is that tender point, which can be taken as a pain, the myofascial trigger point, the fibrofatty nodule. If you look at some people, this is not an easily generalizable statement, but there are some people where they have lax ligaments. So if you find that the general chain of the joints across a limb are relatively okay, but then you find lax in one place that correlates to this, you could think along those lines. Because it's more of a concept than something raw and objective, it's hard to say anything more than that. But the more and more you move the joints around, the more you get a feel for the proximal and distal joints, you get an idea of what patterns are emerging. This is very much a right brain skill. It's not a left brain skill. That's the hard part to these things.
There is one more question. What dilution of local anesthetic you use during your prolotherapy of myofascial trigger points and other areas like other joints like knee and shoulder?
So this is where things get a bit tricky. We just finished an RCT, double-blinded, with 5% versus 18%. 18% group got very fast relief versus a 5% at 1 month, but at 3 months they were the same. So 18% gives faster relief, but at 3 months they're not that much different. The people who are in the 5% group, out of the 30, I think, 3 came back even worse and needed to get an 18% injection. So in general, if I'm doing classical prolotherapy on ligaments, I'll go 18%. If I'm doing myofascial trigger points, I'll go 18%. We do sciatic nerve hydrodissections, and I use a 5%.
Okay.
I don't go intra-articular yet.
What book you will suggest to the participants of the webinar for regarding this myofascial chain? Any specific publication or any book?
I will dig up the books. I read them once upon a time and managed to forget them, but I'll put the name in the IAPMR group for everyone.
Yes,
It's
yes.
a book called Anatomy Trains or something along that line. It has a Western author on it. It's
Yes.
more along the lines of kinesiology.
Please post that author's book, author of the book and details of the book in the IAPMR group.
Sure.
Okay, so there is no more question in the chat box. Thank you very much, Dr. Ravi Sankaran, accepting our invitation and with a discussion a new topic besides the conventional presentation on pain shoulder. So this is really interesting. This myofascial chain concept in our OPD practice, because of Ross OPD, we don't get, but still we should keep patient. At least those patients are refractory to the your pain management. We should think about that. Something wrong behind besides the behind that. So we have to look for the cause. Then only we can come to a conclusion. Yes, there are other things also can causing shoulder pain. So thank you very much. Thank you all participants for joining the webinar. And at the end, I must thank the PR team of IAPMR providing this Zoom platform for organizing this academic webinar. And I thank all my colleagues for supporting us for organizing this webinar. And last but not the least, thank you very much, Dr. Ravi Sankaran. Thank you.
Good night, guys. Thank you. Have a nice weekend.
Thank you. Thank you.